Hello, class, and welcome to Psychological Assessment. This week we're going to be exploring objective assessments. My name is Dr. Neil Soggie, and I am your instructor for this course. So this week matters because counselors often encounter personality and symptom inventories in real practice, and even if they do not administer every major instrument themselves, they may read reports that include objective personality findings, work with clients who have already completed structured inventories, or use selected symptom measures within their own scope. And so part of this lecture is to give you a strong sense of assessment literacy when it comes to these kind of objective personality measures. And they're different from open-ended interviewing or projective methods because they rely upon very structured items and standardized scoring. And the client usually responds to clear statements or questions, and those responses are converted into interpretable scales or a profile pattern. And that structure can be useful because it creates consistency and allows comparison across people or across symptom patterns. And these tools may help us to understand several different things. First off, help us understand current emotional distress, any longer standing personality traits, behavioral tendencies, coping style, and sometimes the person's approach to assessment itself. And the last point is very important. In personality testing, we are often interested not only in the content of the answers, but also in the response style. Is the client being open or defensive or exaggerating or minimizing or confused? And trying to look unusually healthy or trying to look unusually impaired. So a good personality assessment often depends upon noticing both the profile and the way the profile may have been shaped by the person's way of responding. So for counselors, this matters because personality measures can easily be misused if they are treated as labels instead of just a tool. And a score is not a personality verdict. A profile does not replace a clinical judgment. Use your own intuition and your own experience as well. And a personality inventory should never be interpreted as if it reveals the entire truth about a person, especially without context. Just as we discussed with cognitive testing, personality findings become most useful when they are integrated with a interview, with other data, with how the person is functioning, with their overall clinical history, within their culture, and within current stressors. So another thing I want you to keep in mind is that as counselors, and a lot of you are going to be going into addictions counseling in particular, or maybe you'll go on to do a master's in counseling. And your practical task is not to worship the profile or not to ignore it. Your task is to ask some simple questions when you have this profile. What does this pattern help explain? Does it suggest something that might be clinically important, like depression or anxiety or defensiveness? And defensiveness can be a very powerful impediment to the growth of the person. Or is there minimization? Or is there a broader personality concern that needs to be focused on? All of these questions can be very helpful in light of an objective assessment. So that's the kind of thing I want you to think about. Now, as we get into today's lecture, as always, I'm going to tell you a little story about somebody that's important within this field. And then we'll cover three main themes. And the first theme is that objective measures assess patterns. We're not going to get the whole picture. We're not going to get the minute detail. We're not going to be able to read people's minds. But what we will be able to do is detect patterns, because that is what instruments do well. A profile might suggest anxiety or trauma-related distress, or somatic concerns, or suspiciousness, or emotional instability, or some chronic interpersonal difficulty. And the point here is that measures rarely tell us one simple thing. They show a pattern that may help to explain some of the dysfunction within the person's life. And so it's for us to work with the client based upon what we know to help to tease some of these things out. And remember, the client might deny some of these things, particularly if there's defensiveness. It's something to be mindful of. And the second theme I want to explore is that there are response styles, and that matters. A profile is not just shaped by symptoms. It's also shaped by how the client answered the test. And some people are very open, but some people are defensive. Some people minimize problems because of things like shame or fear or denial, or maybe they have legal concerns. And so we need to be mindful of that. And a good test will also give you a sense of the response style as well. And the third main theme that I want to explore is that profiles inform care, not labels. Our intent by giving assessments is not to simply give labels. That is a harmful way of using an assessment. An assessment is intended to help the person. And if you're not using it to help the person, then you're not using the assessment tool ethically. A personality inventory should help us think more clearly about treatment, not more lazily. If a profile suggests significant depression, or high anxiety, or trauma-related distress, or chronic anger, or suspiciousness, or emotional instability, the next question is, what does that mean for treatment planning? Does the client need more structure, more rapport building, more trauma-sensitive work, more relapse prevention support, or do they need a referral of some kind? Now, on to our story. And our story is about Stark Rosencrantz Hathaway. And Hathaway was born in 1903 and was a major figure in clinical psychology at the University of Minnesota. And he's best known for developing a very famous test. And the test is known as the Minnesota Multiphasic Personality Inventory. And if you continue on your work in the field of psychology and behavioral science, you will come to really appreciate the Minnesota Multiphasic Personality Inventory and the work of Stark Hathaway, as well as a neuropsychiatrist by the name of Charnley McKinley. Because together they developed this tool. It's known as the MMPI, and now there have been revised versions, so now we have like the MMPI 1, the MMPI 2, and so on. Now, the University of Minnesota historically sources Hathaway as a major department figure, and developed this tool around 1937. And he continued on in his life and worked at the University of Minnesota Hospital through and eventually died in 1984. What made Hathaway especially important was not just that he helped create this famous test, it was the method behind the test. The MMPI was designed as an objective aid in psychiatric evaluation, and between Hathaway and McKinley, they used an empirical approach to scale construction rather than relying only on face valid descriptions of personality. In other words, they were trying to build scales from items that actually differentiated clinical groups from comparison groups, not simply from items that sounded psychologically meaningful on the surface. And that approach became one of the defining features of objective personality assessment. So the MMPI is really kind of a standard bearer for objective personality assessment. And this matters a great deal for you as a counselor because it changed the field's thinking. Instead of depending only on unstructured clinical impressions and using the clinician's intuition, like, it seems like this person is unstable. They pushed for an assessment with structured self-report data that would be able to be compared systematically across patterns of symptoms and personality. And so by the late 1950s, the MMPI had become the most widely used objective measure of personality and psychopathology. And it was being used in clinics and hospitals and correction centers and in the military and other high responsibility settings. And Hathaway's work is also relevant because objective personality testing was never just about symptom scales. It is also about how the client takes the test. And so there are different parts of the test that look at how the client takes the test. And are they faking good? Are they faking bad? And in all of that, there's different corrections that help to make the test more accurate. So is the client being transparent? Or are they trying to manipulate things in some way? So all of that became very powerful. So Stark Hathaway is one of those people that brought us the MMPI, which has changed the field significantly. Now, before we can interpret personality profiles, we need to define what an objective personality measure actually is. An objective personality measure is a structured self-report instrument. The client answers standardized items in a fixed format, and those responses are converted into scores using established scoring rules. Now, in general testing language, objectively scored instruments are those in which responses are converted to final scores by a defined scoring system rather than by some free-form examiner impression. So there's a lot of rules to follow. You need to read through the instructions carefully. And in personality assessment in particular, that structure matters because it gives us consistency, and that's the value of objective measures. The same questions are asked in the same way, and the profile is scored using the same rules across clients. Now, this doesn't mean that it's perfect, but it means that it's systematic and that we can compare the results between populations, and that gives us a more accurate picture of populations and where a client fits within a population. And two major examples of objective personality measures are the MMPI, the Minnesota Multi-Phasic Personality Inventory, and the Personality Assessment Inventory, the PAI. Now, the MMPI-2 is described by its own reporting that it is a self-report instrument designed to aid in the assessment of a wide range of clinical conditions. The PAI, the Personality Assessment Inventory, is a comprehensive measure of adult psychopathology that includes multiple clinical scales and validity scales. And the point is, especially important here, the major objective inventories do not only measure symptoms. They also try to tell us whether the profile itself is trustworthy. Some scales look for inconsistent responding, unusual over-reporting, defensiveness, or attempts to present oneself as unrealistically favorable. And so it helps you to look at what do these patterns suggest and how can we interpret these patterns. Why might someone be trying to look especially favorable? Is there defensiveness in the whole counseling process? The other thing to be mindful of, and that I want to kind of reiterate this week, is that while these objective measures are good, and they're structured, and they're standardized, and they're psychometrically strong, they are still just one source of data. And so counselors need to, and particularly if you go on into a profession like a psychologist that is doing psychological assessments for a living, you need to use a battery of tests. You need to use multiple sources that you can use to corroborate with each other, and then you can have a more accurate picture. Just one personality test or measure is just one source, and we need to be mindful of that and use it in that way. It's not the answer of all things. It is one source, one data point that we can use in our clinical judgment. Now, let's go on, and I want to give you a little bit of an example and talk a little bit about construct validity and objective psychological assessment. When we talk about construct validity, that asks whether a question or scale actually measures the psychological idea it claims to measure. That's what a construct is. A construct would be like depression. Okay, what is depression? It's not something that weighs anything, or impulsivity. You can't measure the temperature of impulsivity. It's a construct. It's an idea that is formed, and we need to then, once we have this idea, how do we measure that? We measure that by objectifying that. So that's what when we talk about construct validity, that's what we're talking about. In personality testing, that matters a great deal because we are rarely measuring something directly observable. We do not directly see social anxiety. We do not directly see depression or impulsivity. We infer those constructs from patterns of answers, behavior, and functioning. And here I'm going to use some instructor-created sample items. So these aren't going to be proprietary ideas, but for example, if you're looking at social anxiety as a construct, part of that is going to be fear of negative evaluation. So if you had a construct for a scale of social anxiety, one of the things you might be looking for, it might say something like, I avoid speaking in groups because I expect people will judge me negatively. And why does that item fit the construct? Because it captures two important features at the same time. First off, being fear of being judged and avoidance of a social performance situation. And this is more specific than simply saying, I don't like groups. It points toward anxiety tied to evaluation. Another item might be, even when I know the answer, fear of embarrassment keeps me from speaking up. And this one is helpful because it separates fear from ability. A person may know the answer, so the problem isn't lack of knowledge. The item is targeting inhibition because that's caused by embarrassment and fear of negative evaluation. And that's the basic logic of construct validity. The item should map onto a core feature of the construct. And that's the kind of thing I want you to be mindful of. And when you have that, then you can start to see the pattern. So construct validity is very important. And one of the most important rules in objective personality assessment is this. Don't interpret the clinical scales until you have looked at the validity scales first. Now, in MMPI instruments, they're built with validity scales, which basically say, yeah, they followed the rules and they were accurately trying to answer these. The personality assessment inventory likewise includes validity indices designed to detect factors such as trying to distort results, or not paying attention and just giving random answers, or confusion or exaggeration, or malingering, which is kind of faking it, and defensiveness. So for counselors, this kind of thing is important because it tells you the client how the client's approached the assessment tool. Some clients answer openly. Some minimize problems because of shame and denial and pressure or fear of consequences. Some over-report because they are desperate to be understood and highly distressed or responding in an exaggerated way. And others answer inconsistently because they're confused or intoxicated or reading poorly or simply not engaged. So the first question is not what diagnosis fits this profile. The first question is actually, can I trust this profile enough to interpret it? So the first thing you do is look at the validity indices. And once you are convinced that that the client did take the time to do a good, valid assessment, then you can start to look at the meanings behind it. And if there's some question about the validity and the pattern, then let that be part of the process as well. And after checking whether the profile is broadly interpretable, the next step is to understand the major response styles that can shape personality results. The first is underreporting. Is the person being defensive or minimizing this? And a lot of scales are designed to detect intentional underreporting, including unusually favorable self-presentation. They're wanting to make themselves look good, that they have uncommon virtues. And what they might be trying to do there is they're afraid of consequences, or they're trying to protect something in their life. The second question is, are they over-reporting? Are they exaggerating what's going on? Are they trying to look worse than they actually are? And the third is inconsistent reporting. And oftentimes there will be questions within, say, the MMPI that are very similar, and that if you're reading them and being honest, that the person should answer the same way for both questions. And if they answer differently for those questions, then that gives the assessor, there's something going on here as far as inconsistent reporting. So the response style gives you a sense of some valuable clinical information. It tells us about shame or denial, or crisis, or confusion, or cognitive difficulty, or impression management. And any one of those things can be important when we're looking at this. So it isn't as simple as doing the profile and then reading it. There's some steps that you need to go through. But once you've looked at validity and decided that the profile is interpretable enough to consider, the next step is to do some reading of the substantive clinical scales, because there will be some important scales. Like, for example, the MMPI is organized into psychopathology scales. There's higher order scales, including emotional and internalization dysfunction, thought dysfunction, behavioral and externalization dysfunction. And it also includes more specific problem scales underneath those broad domains. And the same basic logic appears in the psychological assessment inventory. There's clinical scales, there's treatment consideration scales, there's interpersonal scales. And for the counselor, this is helpful because it keeps us from overreacting to one elevated scale. If you see one high scale and immediately say, this client has that disorder, you are probably moving too fast. A stronger approach is to ask, is this profile mainly internalizing, mainly thought disturbed, mainly externalizing, mainly somatically focused, or mainly interpersonal? And then you can ask how that broad pattern fits the interview with your mental status exam and the client's history and current functioning. And so all of those things can go together. Now, just imagine a client has a profile that suggests thought disturbance, and the interview also shows suspiciousness and unusual beliefs and disorganized thinking. In that case, the profile becomes more concerning, and for the counselor, that doesn't mean immediately announcing schizophrenia, but it does mean thinking more seriously about a psychiatric referral or medication evaluation or higher level assessment. So all of those things are things that you need to be mindful of as you go through this. Now, once you've considered validity and broad clinical patterns, the next question is, how does this profile help us with treatment? And this is where objective personality assessment becomes especially useful for counselors. Some measures are not limited to symptom scales. They also include scales that help us think about treatment engagement. Things like interpersonal style. And so, like, for example, the psychological assessment inventory includes 5 treatment consideration scales and 2 interpersonal scales. The MMPI also has an interpersonal scales that helps us to understand a little bit of how people function. One area might be aggression or anger. If the profile suggests elevated aggression or irritability or hostility, that doesn't automatically mean that the client is violent, but it does tell the counselor to pay closer attention to frustration tolerance, impulse control, conflict style, and safety. In addictions work, anger plus poor impulse control may increase relapse risk, so that's something to be mindful of. Or it might increase domestic conflict or treatment disruption. So this means the counselor may need clearer boundaries, stronger structure, and more direct safety and coping work in order to help the client. Another area is suicidal thinking and self-harm. And I can think of a tool that I use quite a bit that is an objective measure that's called the FAST, the Firestone Assessment of Self-Destructive Thoughts. So if a treatment-related profile raises concerns here, the counselor should not treat it as just another elevated profile. It should trigger a more direct suicide assessment. Review things like protective factors, like the self-destructive thought patterns of the person, and that should be a clinical focus, plus perhaps possible referral for psychiatric evaluation, or maybe, if there is immediate concern, for emergency referral. There can also be interpersonal styles. So like I already mentioned, the psychological assessment inventory has interpersonal scales, and they're things like dominance or warmth. And each of these can give you a sense of how the person tries to engage with others. Are they being passive and warmer, more distant, or are they being more controlling or more detached? And each one of these can give you some insight into how the person deals with their problems and with those around them. Now, one of the biggest mistakes in personality assessment is treating the profile as if it were the entire case, and that's never the case. It is not. A personality inventory can add important information, but it should always be interpreted alongside the clinical interview, the mental status examination, the person's history, and current functioning. Official MMPI guidance on things like this says that test findings should be considered in the context of the test taker's background and interview and supplemental tests and relevant information. So there's a lot of things that need to go into this. Is there fit? Have you clarified some of these things? Does your other information complicate the interpretation of things? So use your clinical judgment in this assessment process as well. Remember, that's only one bit of information. And one of the most important practical uses of the objective personality assessment for counselors is knowing when the profile suggests that routine counseling is not enough. And that is when it's important to do a referral. And that's one of the great values of these kind of tests. A personality inventory does not make referral decisions by themselves. It doesn't come up and say, oh, you need to refer this to somebody else. But it can give you a sense of, this is above my pay grade, or there are a limited amount of things that I can do to help this person, and they also need medication. They might also need institutionalization. But it can strengthen concern when the profile, the interview, the mental status exam, and the client's history all point in the same direction. And so it strengthens your consideration of referral along these lines. So, like, one major referral signal is a pattern suggesting thought disturbance. So when there's thought dysfunction, and there's chronic thought-related findings, persecution, aberrant perceptions, and disordered thinking, or hallucination-like experiences, or loose association, or impaired reality testing, then counselors should realize that this is likely a very strongly biologically based issue, should likely, at the very least, result in a psychiatric consultation or referral, rather than simply trying to treat the case on their own. Because a counselor's success is going to depend largely upon the client having the ability to use positive thought processes. But if there's thought dysfunction, then that you're already hamstringed. And so you need to kind of be mindful of that through this process. Now, I want to take just a moment and kind of think through how you would use an objective personality profile in the real world. Remember, you're not acting as a psychologist giving a full interpretive report. You're acting as an addictions counselor or a master's level counselor who has been given structured personality data and now has to decide what it means for treatment and safety and possible referral. So we just kind of do a little bit of a simulated case and gets you to think through the first steps with this. So the first step is always the same. Check validity first. Before you care about the symptoms patterns, you need to ask whether clients responding looks open or whether it's defensive and exaggerated or inconsistent or confused. The next step then is to identify the broad clinical patterns. Is the profile mainly internalizing with depression, anxiety, worry, and emotional stress? Or is it mainly externalizing with anger, impulsivity, and acting out risks? Then we come to the third step. So once we've kind of have a sense of the broad clinical patterns, then we come to the third step. We know that it's trustworthy. We know the general patterns. Then we can start to compare the profile with what other kinds of information we have. Does this match with what we've talked with the client about, with their interview, with their mental status exam, and the real life function? And if the profile suggests severe distress and the client also looks exhausted and hopeless and impaired in daily life, then the pieces fit. But if the profile suggests serious thought disturbance, but the interview is calm, coherent, and reality-based, you don't force a match. You ask whether the profile was distorted, or whether the context matters, or whether more assessment is needed. And then you come to step 4, where you think about what are the treatment implications for this. Does the client need more rapport building because the profile suggests that they have mistrust and defensiveness? Or do they need more motivational interviewing because the profile suggests that treatment rejection is high? Do you need more structure because anger and impulsivity and substance risk are elevated? Or more direct safety assessment because hopelessness and self-harm are concerns? All of those things are things to be mindful of. And then finally, you need to ask the referral question. Is outpatient counseling enough? Or is there a need for referral for major thought disturbances or major suicidality or extreme externalizing risk or inability to provide any kind of other information? So that's something to kind of be mindful of. So let's just kind of walk through a little scenario. We'll call this client Nina. And Nina is an outpatient substance use treatment, and her profile shows that it's broadly valid but is somewhat defensive. There's high emotional distress. They're evaluating, there's elevated levels of anxiety and depressive features. There's elevated stress. There's low perceived support. And when you interview Nina, Nina reports that she's holding it together, but also describes that she has some insomnia. Now, in a case like this, if you're giving just kind of a weak assessment, you might say that Nina has a depressive personality and doesn't want treatment. But a more accurate interpretation, I think, would be that Nina's profile suggests significant internalizing distress with anxiety, depressive features, stress, low perceived support, and the somewhat defensive responsive style suggests that distress may actually be understated in some areas, that she has her guard up. So hope you can just see that there's different ways of doing this, but the steps of going through the basics of ensuring that there's validity, that you see the broad patterns, and that you can apply what the assessment is telling you with your own clinical interview, your clinical intuition, what the mental status examination tells you, and bringing all of that together to help it make sense. Now, let's just close out our lecture a little bit with a little bit of review of some of the basic key terms that I want you to kind of remember for this week. The first key term is objective personality measure, and that is just what it says. It's an objective personality measure, is a structured self-report instrument in which the client answers some standardized items, and the responses are converted into scores and profile patterns using fixed scoring rules. So it's very specific rules that so you need to take some time and follow the standardized scoring, the structured scaling, and then from there you make your broader clinical use. And a couple of tests that are measures that I described in there were the MMPI and the PAI, the Minnesota Multiphasic Personality Inventory and the Psychological Assessment Inventory. The second key term is response style. And response style refers to the way that the client approaches the test. A client may answer openly. Sometimes they're going to be defensive. Sometimes they're going to answer inconsistently. Some are going to exaggerate things either positively or negatively. And so we need to look at the validity scales to ensure that there is not distortions or over-reporting or inconsistent reporting. And one of the ways of evaluating a test is through construct validity. Having a good construct is very important. Having a good conceptual idea. You can say, we're going to be measuring depression, but what does that mean? How are we defining that construct of depression? That's the important thing. Construct validity asks whether an item or scale actually measures the psychological idea it claims to measure. Now, I've mentioned this in earlier lectures, and we've used a few tools to kind of go over things like fear and negative evaluation. But a good item doesn't just sound plausible, it reflects a real feature of the construct and contributes to the meaningful pattern of interpretation. And so that's why it's important. And when it comes to our quiz question or our review question, which response best reflects good counselor use of an objective personality profile? And I would suggest here that the thing that you need to do is option B, which is read the validity indicators first, then interpret the broad patterns in the context. You always need to look at the validity in order to kind of decide whether or not it's even worthwhile looking at the rest of it. So, in order to close out our lecture for today, the main idea that I wanted to get across is that objective personality profiles are useful when they are interpreted carefully, contextually, and with attention to the response style. So, validity comes first. Before you care about the clinical scales, you ask whether the client answered in a way that makes the profile interpretable. Then you look at the broad patterns. There isn't any instant diagnosis. You need to look at the kinds of information that this profile is giving you and then match it up with other patterns that you have found from your interview, from your mental status examination with the client's history, and with what you know of their real world functioning. And once you've done that, then you can move to understanding the profile, integrating all of the pieces. And if the profile suggests something that needs to be changed, like distress or impairment, then you can adjust your planning, your treatment planning for that. Remember, the goal of an assessment is to help with treatment planning. If a client is highly defended or highly stressed or angry, that can help to inform your treatment planning. So the more information you have, the more that you can use that to help the client. Remember, our goal is not to label or to denigrate the client. The goal is always to help with treatment planning. Hope you enjoyed this lecture, and I will see you next week. You take care. Bye-bye.